Meet Dr. Alex, a passionate researcher studying diabetes. He wants to understand how lifestyle and medications affect diabetes management. But as he begins, he realizes a big challenge: bias. Bias can distort research results and lead to misleading conclusions. Let's follow Dr. Alex's journey as he uncovers different biases and learns how to reduce them. Dr. Alex starts his study by selecting participants from a hospital diabetes clinic. He gathers data on their sugar levels, medication use, and diet. But wait, what about people managing diabetes at home? By only selecting hospital patients, he's missing a huge part of the population. This is selection bias. To get a more accurate picture, Dr. Alex decides to use random sampling and recruit a diverse group, including those who don't visit hospitals frequently. As months pass, Dr. Alex notices a problem. Many participants, especially those experiencing side effects from medication, stop attending follow-ups. This is attrition bias, where dropouts can skew results. If only the healthiest and most motivated participants stay, the findings may not apply to real-world patients. To reduce this bias, Dr. Alex ensures better follow-up, uses intention-to-treat analysis, and makes participation easier for everyone. Selection bias and attrition bias are two common biases at participant recruitment stage. Dr. Alex then asks patients about their past diet and physical activity. But some remember details differently. Some overestimate their healthy habits, while others forget how often they exercised. This is recall bias. To reduce it, Dr. Alex decides to use food diaries and activity trackers instead of relying on memory alone. Dr. Alex also measures blood sugar levels, but there's an issue. The glucometer he's using gives slightly incorrect readings. This is measurement bias, and it could mislead his conclusions. To fix this, he switches to validated, standardized measurement tools and ensures calibration. As the study progresses, Dr. Alex realizes that some patients in the new treatment group get more frequent follow-ups and counseling, while the control group receives standard care. This is procedure bias, and it could make the new treatment appear more effective simply because those patients got extra attention. To prevent this, Dr. Alex ensures equal follow-up and monitoring for all participants. Dr. Alex is excited. He believes the new diabetes drug should work, but could his expectations be affecting how he interprets patient improvements? This is observer-expectancy bias. To avoid influencing the results, he switches to a double-blind study, where neither he nor the patients know who is receiving the real drug. Recall bias, measurement bias, procedure bias, and observer expectancy bias are common biases at stage of conducting research study. Dr. Alex then looks at breast cancer screening studies. He compares outcomes and survival time of patients detected through screening with those who were diagnosed based on clinical appearance. Patients diagnosed early through screening seem to live longer than the ones who are diagnosed after clinical appearance. This could be a false impression of increased survival time simply because the diagnosis was made earlier in the disease course and not because the treatment is more effective. This is lead time bias. To avoid misleading conclusions due to lead time bias, Dr. Alex compares mortality rates in screened versus unscreened groups. He adjusts survival based on disease severity at diagnosis, also known as back-end survival. Dr. Alex also discovers another issue in screening studies. Screening is more likely to detect slow-growing, less aggressive cancers, while fast-growing, aggressive ones are less likely to be diagnosed early through screening. This is length time bias, which overestimates survival rates between patients with slow-growing and those with aggressive cancers. To reduce this, Dr. Alex uses randomized controlled trials to examine disease mortality rates between the screening group and control group, rather than just comparing survival rates of detected cases. Comparing both together, the lead time bias overestimates survival duration due to earlier detection by screening than clinical presentation, whereas the length time bias overestimates survival rates due to the relative excess of cases detected that are slowly progressing. Dr. Alex has learned a lot. Bias can distort research conclusions, but understanding bias is just one part of conducting reliable research. Choosing the right study design is just as important. Check out our videos on study designs to learn more. Like, share, and subscribe for more medical research insights.